Hello and welcome to Single Payer Radio. I'm Paul Hoppy, broadcasting on the WFMP 106.5 Forward Radio Community Network here in Louisville, Kentucky, where news, information, and entertainment is available 24 hours a day, 7 days a week. The views and opinions expressed on our show are those of the speakers and not the station. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded single-payer healthcare system. Simply explained, it's Medicare for all, only enhanced to cover dental, vision, and hearing, and prescriptions, starting at birth and covering everyone. Catch this program at 2 p.m. Mondays, 7 a.m. Tuesdays, and 11 a.m. on Wednesdays. We also stream our show on SoundCloud so you can listen anytime. This radio station relies on volunteers like myself and your ideas and donations to keep us on the air. Today, Drs. Mike Flynn and Gene Shively join me as co-hosts, and they have invited a learned guest. So let's jump right in. Mike?
This is Michael Flynn, retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer that any comments I make represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville. Our topics today, topics two, are pain management and addiction, and we have a special guest here to discuss those issues with us and with our listeners. James Patrick Murphy is the manager, the owner of the Murphy Pain Center in New Albany. Got his medical degree at the University of Louisville. Did an anesthesia residency at the University of Louisville, a pain management fellowship at the Mayo Clinic, and a master's in medical management from the Marshall School of Business in California. And he has been an advocate for the holistic approach to addiction issues. So, Pat, thank you very much for coming on. And as we have done in the past, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them. And then Gene will begin with the conversation. So, Pat, the floor is yours.
All right, thank you so much for that kind introduction. And also thank you for allowing me to come on to speak to your listeners and to talk about this important issue. It's important to everybody because I think everybody really has addiction issues, either in their, family or in their life or somebody that they know. It's almost impossible to find somebody whose life has not been touched by addiction. And so it's good that we talk about it. And as a physician who treats addiction, I really want to make sure that we start out with the understanding that there's a lot of heartache and trauma and issues that go into this disease. But if we view it as not a moral issue, if we view it as something that is a disease process that's treatable, and if we can approach it like we would other disease processes, I think we can really make some difference. The problem is when we put it in a box and we stigmatize it and say it's somehow not like other illnesses that we treat, I think we get really going off on the wrong directions, and we do things that are maybe we hope are productive, but ultimately can make things worse. That's been the history of our country's approach to addiction throughout. Since we've been a country, probably throughout since we've been a human race. But we've learned a lot about it. We've learned so much about it, and we do have ways to treat various addictions in this age. And I'll touch upon some of those today. Kentucky is like many states. They struggle with this. We have a high percentage of people that have these issues in our state. A lot of it has to do with the economic situations and the social situations in difficult areas, and it's all across the state. But we know how the opioid crisis has particularly affected Appalachian region, the mountainous region of eastern Kentucky, but for various reasons, not necessarily because of the people there, but because of some of the unique situations that that face those communities. But there's no community in this state that is immune from this. I mean, you can go to any, I don't care how affluent you are or what resources you have, but every area in this state has been touched by this disease. So I think we're trying to make progress, particularly in Kentucky. There are some things that we've done good, things that we've done bad, and I think as we go through this conversation today, we'll talk about some of those. I also want to say that I am a member of various organizations, and including the American Medical Association and the American Society of Addiction Medicine, the Kentucky Medical Association, University of Louisville School of Medicine. I am speaking today on behalf of just myself, so I'm not speaking for anybody else. So these are my opinions ascribed only to me.
All right, that's great. Gene?
Yes, this is Eugene Shavley. I'm a retired surgeon from Campbellsville, Kentucky. I practice at Taylor Regional Hospital, and I was on the clinical staff at the University of Louisville. And what I have to say is just my own thoughts and not those of Taylor Regional Hospital or the University of Louisville. My first question is Kentucky keeping up with the laws the way they should be with Suboxone?
Unfortunately, no, we are not. The Suboxone is buprenorphine. That's the generic name for it. And typically, we think of Suboxone, it's kind of attached to the antidote for opioid, which is naloxone. And it was thought that combining those drugs are protective. Think about, people get, you've heard of a Percocet before, where a Percocet is a combination of oxycodone and acetaminophen or Tylenol. So it's a combination drug. Suboxone's kind of that same way. Well, but buprenorphine is the actual medication that treats the opioid use disorder. So it's a very, very effective treatment for people that are addicted to opioids. It doesn't work for really anything else, addiction-wise. It actually helps with pain, believe it or not, but it's not legal for pain in Kentucky. It is other states, but not Kentucky for some reason. But we're trying to get that changed. But Suboxone is one of the most effective addiction medicines that we have ever come up with in the history of mankind. It actually is very effective in preventing death from opioid use disorder, and you can see studies from the CDC that talk about 50% reduction in overdose deaths if people can have access to buprenorphine. Other studies have been even higher in terms of overall mortality, because you got to remember, people that die from addiction don't just die from overdose. They die from infections and hepatic diseases and lots of other things too, just for poor health because of the addiction process. So there's a lot of mortality that is related to opioids that is not just overdoses. And treatment with buprenorphine is like, maybe up to 70 to 80% effective in decreasing overall opioid, mortality, and not just overdoses. But you'll see that the 50% reduction in overdose death rates talked around a lot. So it's a very effective medication. Problem is, it is a partial opioid. So, I think that this state, a lot of us are in kind of a PTSD from the opioid crisis, the opioid prescription drug crisis, which is really in its heyday back in, around the 1990s and the first 10 years of this century, when there was really a lot of overprescribing of opioids for a number of reasons. I think many doctors were led to believe by pharmaceutical companies, as well as the FDA itself, led doctors to believe that some of these medications were not nearly as addictive as we thought they were. And so there was an idea that we really had to be aggressively treating pain, otherwise we were like being cruel to patients. So this overprescribing, in a sense, happened, And but that's gone down. I mean, over the past 10 years or so, the overall prescribing rate of opioids in this country has gone down like 50%. However, in the same time period, the overdose death rate has gone up almost 200%. So you think about it, they're not really connected. But there was a problem clearly with these pill mills and prescribing of opioids. So laws were passed in different areas, and Kentucky had a law that was passed about. It was in 2012, and it got really curtailed the prescribing of opioids in this state. But along came a drug called buprenorphine or Suboxone that was not really a full opioid. It's considered a partial opioid. And I'll explain that in a minute too. But that came along as kind of a treatment for these people that were suddenly kind of without their pills. So they were still physically dependent on this opioid. They've been taking it for a long time at high doses. They had to have something, or else they would go into withdrawal. They would suffer, or they might buy who knows what off the street. And back then they were buying heroin off the street, which you could find it pretty plentiful in Kentucky, in the back alleys and whatnot. Well, now they're not just buying heroin. The heroin is laced with fentanyl. So, you can see the problem there. But there was this treatment for these people, which was Suboxone. And that came out around, it's been around, before the year 2000. But in the year 2000, our federal government decided, we have these two medicines that we treat opioid addiction really well with. One is methadone, and I think people have heard of methadone clinics, but they're very structured. It's kind of hard to find them, and they can only take so many people, and you have to go there physically to get the medicine. But then there's also this medication called Suboxone. It's not nearly as dangerous as methadone. In fact, it's kind of hard to overdose on it. That doesn't mean it's risk-free. You can't have problems with it. But compared to methadone, it's so much safer. So safe, in fact, that the federal government said, we're going to let our doctors prescribe this out of their own office. In other words, you don't have to go to a methadone clinic to get this effective treatment. Your doctor can prescribe it. So in around 2000, they created a law that allowed doctors to apply for a waiver. And all the doctors that prescribe opioids or any controlled substance have to have a special DEA license. So if you applied for an additional waiver, they called it the X waiver, then, it was easy to get, but you had to apply for it, and then they would monitor that. The DEA would monitor, how much prescribing was going on. So some doctors signed up for that, and we found out that over the years, that as the doctors that actually were prescribing this medicine, it was very effective. So it started out like you could do I think 50 or something like that patients. Then you could do like 100, then up to 275. And then they started letting nurse practitioners do it, and other people with DEA licenses prescribe it. Until 2022, which was, a few years ago, December 29th, it was part of this omnibus bill that was passed by the Biden administration. But in that bill, they did away with all of the waivers. They did away with all of the restrictions on prescribing buprenorphine for opioid use disorder. They did that because it was so effective. Again, I mentioned 50% success rate in decreasing overdose deaths. That's incredible when you think about it. So the government was like, we want our doctors to feel comfortable prescribing this. So that's gone. Problem is, in Kentucky and a few other states, Kentucky passed their own separate Suboxone regulation. Remember how I said they did one in 2012 for the prescription opioids? Well, because the people in this state were turning to Suboxone clinics, to the naked eye, or to the people in the community, these Suboxone clinics kind of appeared to be pill mills again, because people were lining up outside. They were, some of them were in withdrawal, and I think some of the communities had PTSD from the opioid crisis and the prescription crisis. So they viewed these Suboxone clinics as being maybe a problem in their community. So they asked the medical board, this is my understanding, they asked the medical board, do something about this, pass a law. So the medical board passed a law regulation that really tightened up how you could prescribe Suboxone in the state. And they did it in the same way, very similar to how the restrictions on methadone clinics are. So it really became a real deterrent to a lot of doctors feeling that they could prescribe this medicine. So it really wasn't prescribed in Kentucky, and still is not prescribed to the level it needs to be. In fact, the statistics say that only like 1 in 5 people that should have access to this medication actually have access to it. So we have 80% of the people in this state that could benefit from buprenorphine just don't have any way to get it because so few doctors are willing to prescribe it. And a big barrier to this is not just the cost of it and the reimbursement for the doctor's time and everything, but this regulation in Kentucky that is it sets up a lot of barriers that patients have to do, that doctors have to do, and it really is a disincentive for the doctors to prescribe it and for the patients to be able to get it.
Hey, Pat, can you explain what these barriers are for our listeners?
Okay. Well, if first of all, as I mentioned, we've understood that this is a very safe medicine compared to methadone. And in 2022, December 29th, they did away with all these regulations. So the DEA, the CDC, the FDA, I mean, you name it. They were all saying that we want our prescribers to treat this medicine like it was any other controlled substance. Just do doctoring, nothing terribly special or difficult about this, but do what you do as a doctor. Assess the patient. If you feel like it's going to be beneficial to them, you prescribe it, you follow them up, you read about it, but it's not anything difficult to do. But so with those laws being gone and the encouragement to prescribe this medicine because it's so effective, Kentucky has hung on to this 10-year-old regulation that from 2015, and it's over 10 years old now. And what it does is it actually requires more drug screens on patients than a methadone clinic would. And it requires, like multiple visits in the first 2 or 3 months of being seen. And if you don't have that, face-to-face visit, getting transportation to the clinic, paying for that visit, being at that visit, getting those drug screens, and if you don't do that, then the doctors feel like they have to, take you off the medicine. When that's not evidence-based. The evidence says that you maybe adjust things, you don't ignore those things, but you don't necessarily take patients off these medicines when you see these these addictive behaviors. You might need to increase the dose. So you've got barriers that, first of all, it's stigmatizing even to have a separate regulation. Why should we have a separate regulation for this? What makes addiction so special? Why isn't it just like treated like any other illness? And in fact, on the primary care level, where it should be treated by your primary care doctor. Secondly, there's costs. All these visits cost money, and you have to have transportation to get there. And they're very strict about how many visits you have to have. And then the drug screens, the urine drug screens, for example, they're expensive. They can be very expensive. They require confirmation with labs for these things. Other labs that are mandatory to be done that can be expensive for patients as well. Consults they have to get with specialists if there are some abnormalities in some of the behaviors in these clinics, or if your drug screen's abnormal, and they're not available throughout the state. So there's just multiple things that they are making patients do and making doctors document that are costly, and that make it so that a lot of people just throw up their hands and say, well, why should I do this? As a doctor, why should I put myself in front of the medical board and potentially lose my license over this? Well, I'm not getting paid much for it anyway. And these patients are difficult. They're challenging. A patient with addictions usually has social problems. They have a lot of medical problems. They can't oftentimes follow directions because of their addiction. But there's a lot of difficulty from treating these patients as well. But the good side of this is, though, if you will treat it as a physician, and if you will find a way to get the medication into these patients that have opioid use disorder, it is incredibly effective. And it's almost, I won't call it a miracle because that's probably saying too much. But when you think about the death and the destruction and the misery and what happens is because of opioid addiction, and when you have a medication that even by itself is very effective in improving the quality of people's lives, then it really is a pleasure to be part of treating somebody with this condition. So we need to get rid of that law. That law, there's been a couple of bills that are currently being created that will be, I hope, in Frankfurt in January of next year when they have their session, that will force the medical board to eliminate this regulation, because right now they are hanging on to it, and frankly, I don't even know the reason why.
Now, Pat, you've been dealing with the legislature, is that right, or the medical boards about how to change this? Can you kind of give us a little insight about what kind of issues you're dealing with?
Yeah, obviously with the X waiver going away, and it was eliminated effectively, in December of 2022. But the medical board regulation still says you have to have an X waiver, which doesn't even exist. So they're forced then to make some amendments. They have to change it. So the medical board sent out a notice to the doctors that they had updated the regulation. They changed a few things. The Kentucky Society of Addiction Medicine, among other people, have looked at this and said, no, this is wholly inadequate. You have not made the proper changes. It's still, in fact, in some cases, it made it worse. They've made some of the drug screens, for example, even more expensive. I mean, there's been some positives, but a lot of negatives. It's still an incredible barrier. So what has happened is that we have asked for multiple changes, and it's not happened. I mean, they're still they're marching on through with getting their regulation updated, and in fact, apparently on September 9th, it goes before the what's called the Administrative Regulatory Review Subcommittee on September 9th, and they could, they're going to review it, and I think, then they move it on to the next level in Frankfurt to get the regulation approved. But I'm hoping that that subcommittee will see to it to stop it right there, just to stop this process and go back, in a sense, to the drawing board and bring the experts in to actually create, if they want a regulation, let's have one that actually works. But better yet, just do what most states have done, because Kentucky is an outlier now. Just get rid of this old 10-year regulation. We do not need it. The medications is still a controlled substance. It'll still be regulated by the DEA. It'll still be regulated by another law in Kentucky that looks at controlled substances. It will not be the Wild Wild West, but we'll get this effective medication into the hands of people that need it.
Let me ask a couple more questions. What about people who are on Suboxone? How long do they have to stay on it?
That varies from individuals. The way we say it in addiction medicine is there's no one size fits all to this. And the best way I can have people think about it in terms of diabetes. If you think about it, addiction is not just some moral decision that people make. It's actually, we've proven this with MRIs, and we've proven this with studies. You can see that there are areas of the brain that are damaged by the exposure to these opioids, for example. And they're deep in the area of the brain that they control some of our decision-making process, our memories, our behaviors, and actually how we feel about ourselves. The joy that we might have, and they get just terribly damaged by the opioid. But this medication actually hits those receptors in that area of the brain and calms that down. So the patient can think more normal, they can lead normal lives, they can do that kind of thing. Well, if you're a diabetic, for example, and you've had damage to your pancreas, that's where the insulin comes from, you may be somebody that over time, if you're lucky, you could lose weight, you could exercise, you could change your diet, and maybe you could come off the insulin. But there are also people that no matter what they do, their pancreas is never going to create enough insulin or the right amount of insulin. So they are going to need to be on some sort of treatment like that probably the rest of their lives in order to lead a very healthy, long life. But it varies from person to person. Suboxone's the same way. And I think it varies in terms of how long that people need to be exposed. Some people can just be, put on it to stabilize them, then taper over a few months off of it. Others, a few years, and then they can try coming off of it. Others might need to be on it the rest of their life, just to, at some level to kind of control things. And it just varies from person to person. And that's why you have to treat everyone as an individual. Your first thing you want to do is stabilize somebody, show them that it's effective, and then if you have this discussion and they want to come off of it, then you can work to get them off of it. And so you can try to come down off of it. However, I really want to make sure that we remove the stigma of being on this medicine, because it's not a failure of being on it. It's not a crutch. It is a medical treatment for a medical disease. So if somebody does feel like their life is improved by being on this medicine forever, at least until we get something better, then frankly, they should be allowed to stay on it and shouldn't feel guilty about it.
All right,
Well, let
Pat.
me ask you about a couple of other medicine that I've heard about. People who are not stable on taking the Suboxone or don't take it properly. What about Sublocade, the IM medicine, and Vivitrol is being used for drug addicts and alcohol addicts? And when do you use these compared to just the PO other medicines?
Okay, well, let me first of all explain how Suboxone works. It goes under the tongue. You can put it in the cheek too sometimes, but it gets absorbed through the mouth. So typically, people, those Listerine breath things, people used to put under their tongue, and those films that would dissolve. That's kind of how Suboxone works. You put it under the tongue once a day usually, and it just dissolves, and it works 24 hours. So it's a once a day thing. There is also the injectable form. And there's a couple types. One is like one week at a time, for example. But Sublocade, which is the one you're mentioning here, is a once a month injection. So that takes away the possibility that I'm going to miss a dose or run out or whatnot. You get a once a month injection. It goes under in your body, under the skin usually, and then it just it's deposited there and released slowly over the course of a month. And that's a very effective way to get the medicine. The downside of it is it's a shot, so people need to be up for that, the injection. Secondly, it's expensive because it's not generic. That's a newer medicine, and there's no real inexpensive way to get that. But when you think about the cost of addiction in our society, and in terms of just healthcare issues and crime and just loss of productivity and misery for people's lives, the investment in Sublocade for somebody who can somehow get it is a really, I think, a good investment, and you get definitely return on that. But that Sublocade's a once a month injection, and the Suboxone is a daily use under the tongue.
Pat, let's give our listeners a kind of an overview of what's going on locally. So could you kind of give us an idea, say in Louisville, whether drug use, as an issue is increasing, decreasing, or staying the same? And then I'd like you to, if you could, again, share with our listeners some some of the predictive factors that go into getting somebody into using drugs?
Okay. In terms of locally, I think Kentucky and Jefferson County in particular has mirrored the rest of the country. I think you may have heard our governor a few months ago talking about how pleased he was to see there was about a 30% reduction in overdose deaths over the past year. And there had been like a 9% reduction the previous year. And again, I think that's something to celebrate. We should just all be very happy about that. That's great to see that anytime there's less death, that is a wonderful thing. However, that's kind of what the rest of the country saw. That's kind of what everyone saw. And the experts in this field don't really know exactly why that's happened, but the theories behind it is that there's a lot more Narcan out there. Now, Narcan or naloxone is the antidote to the opioids. Used to have to get it over, from a prescription, but now you can get it over the counter. Actually, anybody can usually get it at a pharmacy, and they'll, without a prescription. They give it out at the fair sometimes. I'm part of the what's called the Kentucky Harm Reduction Coalition, and what we do in this organization, one of the things we do is distribute Narcan. We train people on how to use it, and typically it's just nasal spray. So if you can squirt up someone's nose, you can reverse their opioid overdose. It's not permanent, and it will wear off. And if the patient has too much fentanyl or heroin in their system, they can go back to sleep, or they can actually the overdose can come back. So sometimes you have to redose it, but it is very effective for preventing death. If you can get to somebody who's overdosed on an opioid, you can really save a lot of lives just by having Narcan. So that's one thing. And we have a lot more availability of Narcan. It's in a lot of places, and a lot of organizations are stocking it and using it. Frankly, it's like, I think of it like the EpiPen for somebody who has a bee sting, bee sting allergy that can, basically kill you if you get stung by a bee. They carry these EpiPens around, and Narcan's like that. Narcan can reverse a life-threatening, situation, but it doesn't treat the medical condition. The EpiPen does not get rid of the bees. The bees are still there. The Narcan does not treat at all the cause of the addiction. So we need to be able to have people access to Narcan and then also treat the cause. There has been a little bit more prescribing of buprenorphine, not a whole lot more around the country. Unfortunately, Kentucky has not seen an increase in buprenorphine prescribing, even with the elimination of the X waiver. Our prescribing has not gone up, and that's for some of the reasons I've mentioned previously, like this regulation. But we have to do better in getting more buprenorphine prescribed. But we have seen a decrease in overdose deaths.
Now that's the
We've
result.
not seen a decrease in drug use, though. The drug use has been is either the same or it's increased. So,
Okay, that's because what you're talking about is a much better treatment, but the drug use itself is either pretty much the same or maybe a little bit more. Is that a fair statement?
Yes, and that's tied to a couple different factors. During COVID, with all the social isolation and people not being able to get access to health care like they needed to, and also the economic downturn during COVID, the overdose death rate just skyrocketed, and drug use really went up as well. So since we've come out of COVID and less isolation, and people are getting back into treatment and access to treatment in certain areas, we've seen that have a big effect on the overdose death rate too. The big thing is going to be what happened. What do we see next year? Now that we've had this drop to the levels, which by the way are still higher than pre-COVID. So if you get rid of the COVID bump, and you look at what the overdose death rate was prior to COVID and what it is now, you draw a straight line there, we're still going up. So it's come down for some reasons, but the overall trend is still trending upward. So we're not making the impact that hopefully we can over the course of the coming years.
Okay.
Let me ask you a question about what the Trump administration is doing about the fentanyl. Do you think it's going to work? And going after the cartel and blocking the ships coming in with fentanyl from China?
Well, there's in this situation, there's always a supply and demand sort of issue here. And as long as there is a demand in this country and people want to use it and abuse this, or they have a need for it, or as long as there's going to be a demand in this country, then people will find ways of getting it into our country, or making it here. They might come through Canada, but they will find a way. People are, these entrepreneurs, I use the term loosely, these criminals, entrepreneurs are cagey, and they're smart, and they will find a way to get it in. So I think that it's important that we can control things coming into our country, and I don't know the details on what the best way of doing that is. I'm certainly not a law enforcement officer and have never, put myself out as being one, but I do know that any way you can reduce the supply is a good thing. But as long as there is a demand, we are going to, have this problem basically unfettered. And to decrease the demand, we have to, to treat this not as a criminal issue, not as not as something that is a moral issue, but it's a true public health emergency. We did that during COVID. We've done that during other things. If we would put the same attention, the same sort of strategies into it, the opioid crisis and addiction, as we did during these other healthcare emergencies, we would make an impact. We are not doing that now.
Okay, let's go back again and share with our listeners some of these predictive factors that result in this demand, and I'd like you to kind of, if you could go through them, and just to give our listeners a sense of which of these issues affects the frequency of drug use, like one, mental illness, poverty, rural-urban environment, isolation, bullying. I mean, these are all issues that sort of float around out there, and I'd like to, if you could share your opinions about how much of an impact any one of those particular issues is on the frequency of drug use, or the demand that you're talking about. I think that would be helpful, especially for people who don't have a medical background and are just, watching this stuff on television or reading it about in the paper.
Okay. Well, we could talk a whole hour or longer about this subject.
I know, but if you can make it short.
Okay. When I think about what causes or what leads to drug use, and certainly addiction, it's we think of three buckets, three categories. We call it bio, psycho, and social. And there's biological determinants. There's psychological determinants, and you've mentioned some of those, and there's social determinants. You have to kind of be exposed to the agent, whether any addiction, whether it be alcohol or opioids or methamphetamines or pornography or gambling, or just the number of things that can trigger this area of the brain and potentially damage it. You have to be kind of exposure to it. So that's one thing. So your environment's important. If you live in an environment where your peers are using it, or it's commonplace or whatever, then you're more than likely at some point you're going to be using it or exposed to it. Most people have experimented with these things before. So your social environment's important, and what your peers are doing as well. And when I think of social environment, also, anytime there's unrest or in the economic or social environment, then people tend to turn to other things as well. And we've seen that in animal models also. When they're stressed, animals in these models will turn to drugs or things like that to kind of, help with some of the anxieties and things of that nature. There are social anxieties. Before I get off the social issue, sometimes the issue of early childhood trauma or past traumas, that have been unresolved or whatever, they sometimes put you at higher risk. You mentioned bullying. Anything that decreases your self-esteem or self-worth, you might look to something else. Isolation, loneliness, things of that nature. But probably one of the number one issues that we see as being predictive of drug issues with addiction is the genetics. There is, and we don't know exactly, what the number is. It's somewhere between like maybe 5 to 8% of the population have a genetic predisposition to developing an addiction to something. And they may have a dormant gene that when they're exposed to the alcohol or to the drug, that gene gets turned on in the brain. So as you can see, as I'm talking about it being a biological medical model, when you think about a genetic predisposition with a gene that gets activated by being exposed to this agent, the opioid, for example, and then structures in the brain are altered, and dopamine release is very much an issue that damages receptors. You can see how that's one thing. So there's a real genetic predisposition. It tends to run in families. They would say, if you're got a first degree relative, that has an addiction problem, you've probably got the gene. At least 50% chance you've got the gene yourself. So we don't know exactly how it's passed on to people, or there could be some mutations as well, but there's a large genetic component. So we got to understand that. That's the biological aspect of it. Then there's a psychological aspect of it. I mentioned that people that deal with certain things like depression or anxiety or bipolar disorders or other psychological and almost psychiatric illnesses that are not adequately treated can turn to these other agents, and they might find temporary relief for their symptoms. And I hate to say it to anybody out there, I don't want to be a buzzkill, but those of us who turn to marijuana to help treat with anxiety and some of these PTSD, things like that, there is no studies, there's no evidence that shows that it actually is beneficial in any of these conditions. And we talk about medical marijuana. There's no such thing as medical marijuana. There's some people that say they feel better medically, and there are a few conditions, maybe like chronic pain, for example, where there has been some certain chronic pains where there's been some not high quality evidence that it helps, but turning to alcohol or turning to marijuana to treat anxiety, for example, is going down a pathway that is likely to make it worse. So we have this bio, psycho, social, these three different buckets of things. And, of course, genetics is very important, your psychological well-being, and then your social environment. All of those are important.
Let me ask you, you talked about addiction to things like gambling. And I was fascinated. I heard a podcast a few weeks ago where they spent a whole hour talking about revenge as being addictive, and that there was biological and imaging evidence that revenge and gambling showed the same changes as somebody who's addicted to drug or alcohol.
Well, we have codes that we have to, can sometimes use to when we diagnose an addiction, and I'm not aware of any revenge use disorder.
Okay.
But it doesn't surprise anything that's going to be the component that is consistent with all of these addictions is that initially there is this pleasurable thing, or maybe this good feeling about things, and that's the release of dopamine in that part of the brain. And you need to have pleasure in your life. That's how we are driven to do things. We don't want to get up in the morning unless there's some sort of pleasure involved. We don't want to, find the love of our life or our mate, or find satisfaction in doing things. I mean, a life without joy is honestly not worth living. And but that's an important part of our our brain that helps us find warm places to live when it's cold, and find food that we like to eat that makes it nourishing for us. Those things are important. When they get hijacked and damaged by the addictive agent to such an extent that, for example, getting the heroin becomes so much more important than eating or anything else in your life. That's so overwhelming, the drive there, because of that damage to your brain. Then that's how people ultimately die from this. So that's why some of these treatments we have, like the Suboxone, just can calm those receptors down and take away that damaged part of that we call the reward system, stabilize it, so then you can start digging your way out of where you are. You can maybe go find a job. You can maybe repair some of those relationships you have. You can maybe get into some of the psychiatric treatments that you need to help with those conditions, and then just start moving back toward a healthier existence, and ultimately a longer quality of life that's naturally pleasurable for you, not chemically pleasurable for you.
Now let's talk about just a little bit about some of the economics. What, in your opinion, is going to be the impact of this, quote, big beautiful bill, unquote, which I call a big piece of crap, on access to health care for drug users that are currently covered by Medicaid? I mean, as we all know, there's going to be issues with birthing, maternity care, and a bunch of other stuff. So, where does the drug use or health issue and the impact of the changes in access to Medicaid coverage for drug users?
Well, people on Medicaid tend to not have money. That's why they're on Medicaid usually.
Yes, I understand.
And these treatments cost money. We know these treatments work. We know for a fact. I mean, as much as we can know in medicine, and there's nothing ever certain in medicine, as you all know that. But there's things that we are pretty sure work. And these medications, for example, I'd mentioned the buprenorphine, the methadone, even the naltrexone, the Vivitrol injections are helpful. They are so useful and they're so life-saving, but they cost money, and they have to be prescribed to you, and somebody has to see you, and somebody has to, have a visit with you. Usually, it can be telemedicine sometimes, but you got to have access to that, and they're not going to do it for free. There's got to be some coverage for that, and if people that use drugs have no access to treatment, they are going to die. It's a life-threatening illness. It kills people. It's like cancer or heart disease or anything else. Do you know that the number one cause of death for people under the age of 40, I mean, the number one cause of death is not heart disease, it's not guns, it's not cancer. The number one cause of death is overdose. I mean, if you think about that, people in the prime of their life, and this is the number one cause of death in this group of people, and we're not pouring our resources into this. There's other reasons, and I just think I hope that it's just misunderstanding what it is, and we can at some point understand that it is a medical illness. It's not a moral issue, and that we can treat this medical condition with treatments that we know works, and we can pay for it. If we do that, we can make a difference. Dr. Nora Valkow, who was the head of NIDA, the National Institute of Drug Abuse, part of NIH, she was in Louisville in October of last year, and I sat on the front row, and I got to hear her talk. She's probably the number one addiction psychiatrist in the world. And I heard her say that if we had access, if patients that needed these medications, if they had access to them, the overdose death rate would drop by 50% or more. And she thought that was a conservative estimate. She says, we know that because that happened in France in the late 1990s, and they dropped their overdose death rate in France by almost 90%. And I was like, my jaw dropped, and I couldn't, I can't unhear that. When you hear those statistics, and you hear it coming from the top psychiatrist in the world on addiction, and I'm sitting here in Kentucky and we're not doing that, that's when I said, I can't. It's like driving by the scene of a horrible accident. I had to stop. I can't drive past this. So that's why I'm working as hard as I can to try to get a bill passed to get the regulation gone. And then also, we've got to have access to these medications. We can't, and these treatments, we can't have them go away. So I think I don't know the details of this big, beautiful bill, honestly, but if it does, and it is taking away access to people, that have Medicaid that need these treatments, then more people will die. And I can tell you this: when I worked with the Harm Reduction Coalition, we would go down in Portland area, and there would be we had a tent down there once a week. People would come out from under the viaducts. They would come walking up to us, and they would be in the throes of addiction, but then they had that moment where they said, "Well, I would like to try the Suboxone. I think I would like to be on it." And we could open up a chart on them for a U of L chart right then and there, get them signed up, get them started on the Suboxone, and then they could then come down to U of L, and they could be incorporated into the clinic, and they could show up again, and they would have coverage, and they could get other healthcare issues taken care of. That model has to be there. If we lose that, we're just going to be back where we were with the overdose and the death rate, going back to where it was during COVID.
Well, that's one of the reasons why we're doing these programs. France is a country that's focused on providing health care for its citizens. In this country, health care is focused on making profits from every healthcare activity. And until we get past that, I don't see things changing a whole lot. Go ahead, Gene.
What about the rate of drug addiction and treatment in Europe in general?
Oh, in Europe, I apologize. I'm not really sure about what the exactly it is in Europe. I don't know exactly.
All right. Well, let me ask another question. Is lots and lots of family members are drawn into this drug addiction with members of their family, and how can people in our audience who are affected by this, how do they know when to help somebody who's drug addicted and when they're enabling them?
Boy, that's a difficult question, because there is no line that you can draw and say, well, once I cross this line, I'm enabling somebody. I think that it starts with obviously loving them, and that we know that if you have a loved one, you care about them, but knowing what to do. Think of it in terms of if this was a medical illness, if this was heart disease or diabetes, if they were having some chest pain, if they were having severe headaches, if they were delirious because of their blood sugars were out of control, what would you do? You would try to get them medical care. So there is medical care available. So any resources that you can go to, any place you can go to that talk to doctors, that find somebody or nurse practitioner, somebody in the healthcare field that understands it. And they're out there. There are addiction people out there, people that do this, and they can help guide you in that regard. So focus on it as a medical illness. And if you feel like that, I'm not going to tell somebody what to do. If you feel like that you need to provide less or more or tough love or whatever, that's a personal decision you kind of have to make. But there's a concept that we talk about called harm reduction. And of course, there's prevention, harm reduction, treatment, and then recovery support. But the harm reduction means that even if somebody's using, that what you do is you treat them with dignity and with love. And it might mean that there are boundaries, obviously. Well, I'm not going to do this. I'm not going to take you here or do this. But in terms of the things that they need to keep their dignity and show that they're loved, a warm place to live, food, clothing, health care, the things that a community, always welcoming them back into the community. It's something that's a personal decision and no size fits all. But remember that when you treat somebody who's in the throes of their addiction with the kindness and compassion that the harm reduction principles talk about, you are doing the right thing. That is actual health care for them. That's moving in the right direction. I forget what the exact number is, but people that get those type of harm reduction services, just the dignity services, just that I talked about, they're like 5 times more likely to eventually enter into treatment.
Okay, I'm going to give you now.
It'll work later.
We're down to about 3 or 4 minutes, so we're getting close to the end. Gene, you want to ask another question? And Pat, we're going to give you an opportunity to make whatever comments you'd like to make, and then Paul's going to take us out.
Do these people who are addicted to drugs and on Suboxone, do they also need to have therapy?
It varies. I mean, I think that I tell you what, I need therapy.
Yeah.
Everybody could use a little somebody to talk to, So do you need therapy? Tell you what, in terms of preventing overdose and just the medication alone is almost as effective as the medication plus therapy. But most people that get the addiction, get that biological aspect under control, honestly, most people also have an underlying psychological issue as well, which if they don't get that treated, it puts them at risk for not getting full recovery, also puts them at risk not getting the full benefit of treating their addiction. So it tends to be that the thought is that the best model is medication assisted therapy. It's now called something else. It's called MOUD, or Medications for Opioid Use Disorder. The MAT is an old term. And the reason why is because we don't want people to think that you have to have counseling. Because if I'm going to say, well, you can't have your Suboxone unless you go to counseling, then I might miss people that otherwise would do okay with just the medicine.
All right, Pat, last 2-minute warning. You want to make some final comments, and we're about done here.
Yeah, I want people to know that it's a very lonely place when you either have addiction or you limit somebody with addiction, and it's part of the disease process. The loneliness is, and you feel like you're the only one out there. And I want people to know that you're not. Everyone deals with this. I mean, frankly, if you haven't dealt with it personally, one of your loved ones has dealt with it. And I want people to know that there is help, and there are treatments that do work. And we just talked about opioid addiction. There's other addictions that we have medications for that are maybe not as medically successful, but there's other types of cognitive behavioral therapies and things of that nature. And there's no one size fits all. And never give up. Keep working at it, because at some point, you can. This is a treatable condition. Don't give up. There's help out there, and if you've got a loved one that needs it, never give up on them. If you're struggling with this, you never give up. It feels like you're never going to get out of it, but you can. You can.
All right, Pat, thank you very much. You are a great advocate for the humanistic approach to addiction. Paul?
Thank you, Dr. Murphy. Thank you, Mike. And thank you, Gene, for providing us with a delightful program. And thank you, listeners, for tuning in. And I hope you keep coming back to Single Payer Radio. Have a wonderful rest of your day.